Hi guys, so we are going to be going over Unit 10 today, and it's going to be over articulations, otherwise known as joints. So basically joints are functional junctions between bones, and they allow for us to permit parts of the skull to change shape during childbirth. So once we ossify, that's what ends up being sutures later. But essentially, before that time for which they become bone, they are these joints between the two major flat bones, all the major flat bones in the skull, and it allows us to be able to partake in childbirth. And it also enables the body to move in response to skeletal muscle contractions. So essentially there are different types of joints, and I'm going to show you this quick video and then we're going to discuss it afterwards.
Joints are sites where bones join together to make movement possible. Without joints, we'd be unable to run or do push-ups. Now, joints can be described and classified in two different ways. They can be described functionally, or they can be described structurally.
Joints are divided into three different functional classifications based on the degree of movement they allow. These classifications are synarthroses, amphiarthroses, and diarthroses. Synarthroses refer to joints that are immovable. These types of joints are found in places like the cranium. Synarthrotic joints lock bones together. They just won't budge.
The classification amphiarthroses refer to joints that are slightly movable. They're not rambunctious or hyper, but they do move a little bit. These joints are found in places like the vertebral column.
And last, but by no means least, the classification diarthroses refers to freely movable joints. These are the types of joints found in upper and lower limbs.
In addition to all this, joints can also be classified by their structure. The three structural joint classifications are fibrous joints, cartilaginous joints, and synovial joints.
The first structural joint we'll talk about is the fibrous joint. Some joints have little fluid-filled spaces between bones. These little fluid-filled spaces are called joint cavities. Fibrous joints do not have joint cavities. Fibrous joints are joints where bones are united by fibers of fibrous tissue at their joint sites. Fibers. Fibers. Hey, it's fun to say fibers. One specific type of fibrous joint is called a suture.
Now everyone has sutures in his or her skull. These sutures are made up of interlocking or overlapping bone edges that are connected by short fibrous fibers. The term fibrous fibers may sound redundant, but hopefully it'll make you remember the name of the fibrous joint. Two other types of fibrous joints are syndesmoses and gomphoses.
In syndesmoses, bones are connected at their joint sites by long fibrous cords or sheets. Fibrous, get it? You can find an example of this joint in the lower leg between the tibia and the fibula.
Another cool fibrous joint is the gomphosis. Gomphoses are the joints that connect the teeth to their tiny bony sockets in the jaw. They are attached with fibrous periodontal ligaments.
Are you catching a trend here? Fibrous joints use fibers. Another type of structural joint classification is the cartilaginous joint. Now, can you guess what substance connects bone to bone in a cartilaginous joint?
Cartilaginous joints are joints where bones are connected by plates of cartilage. Like the fibrous joint, the cartilaginous joint has no joint cavity. They are amphiarthrotic or slightly movable and are usually found in the axial skeleton.
A good example of a cartilaginous joint would be symphyses.
Symphyses are flat, frisbee-like discs of cartilage between the vertebrae. The proper name for these frisbees is intervertebral discs. Symphyses are also found between the vertebrae and in the pubic symphysis of the pelvic girdle.
The synchondroses are another fine example of cartilaginous joints. The synchondroses are joints made up of superflexible cartilage called hyaline cartilage. These joints are found in structures called epiphyseal plates. Epiphyseal plates are found in long bones like the humerus and the femur. These plates allow for linear bone growth in places like your arms and legs. That's longitudinal growth.
The final structural classification is the synovial joint. These joints consist of bone ends that are separated by a joint cavity filled with synovial fluid. Synovial fluid is a liquid that reduces friction between bones. Synovial joints come in 6 exciting varieties: gliding, hinge, pivot, ball and socket, saddle, and condyloid.
Okay, so that kind of gives you a review of what we're going to talk about today, and some of what we've talked already or about to in the lab. So joints can be classified according to tissue types that bind the bone and to the degree of movement allowed by joints. We talked about this in class a little bit, where you have tissue classifications or the classification based on structure. So this is structure, right? And so it's fibrous, cartilaginous, or synovial. And the degree of movement classification down here, which is function, which is synarthrotic, which is immovable, amphiarthrotic, which is slightly movable, and diarthrotic, which is freely movable. And if you remember on here, essentially, I gave you a hint of how you can remember these by using sadism, right? So synarthrotic goes to immovable, amphiarthrotic goes for slightly movable, and diarthrotic goes for movable. Now, when we talk about each of those, fibrous, so when we're talking about the structural classification, fibrous tissues, they're called fibrous joints because they're made up of fibrous tissue, which essentially is dense connective tissue. And that dense connective tissue basically has a lot of collagen fibers in it. And these guys generally are formed in bones that come in close contact with each other. Right? And so what we're going to do now is we essentially are going to go through all types of the different types of structural classification, starting with fibrous. I'm going to not actually have you watch that because it's terrible, just to let you know. You're welcome. So synarthrotic, really quick, you guys tell me which one of these apply. Are they false joints? Are they B, immovable joints? Are they C, located in the shoulder and pelvis? From what you know, are they D, located in the skull? Or are they E, contain connective tissue? Give you a minute to think about it. So these are considered false joints. They're called false joints because they don't really move, and they end up becoming those sutures later, right? They are immovable. So that leads us to the second. They are immovable joints. They don't move. Now, are they located in the shoulder and pelvis? No, they are located where? D, the skull. And they contain what kind of substance? They would contain connective tissue. So false joints are ones that essentially do not move, like these. And they are immovable. They're located in the skull, and they're made from fibrous tissue. They do contain some connective tissue as well. The dense connective tissue, right? True or false? Amphiarthrotic are freely movable joints. So you should remember what I gave you to remember these, right? And A stands for slightly movable, right? Not movable. So this would be false. Just to help you kind of gauge your understanding, right? So let's talk about fibrous tissues here really quick. So just again, they're made up of what? Dense connective tissue, right? And dense connective tissue contains collagen fibers. So that's what gives it its strength, right? And they happen to bones that are in close contact with each other. So there are three types, right? There is syndesmosis, there are sutures, and they are gamthrosis, are the three main types. So let's look at all three main types in pictures of each. So syndesmosis, which is also known as ligamentos, are joints held together by ligament. And so if you look at this, essentially you can see this between the fibula and the tibia here. And essentially they are basically looking at this area that's down here, right? So these are essentially can help to hold joints together by ligament. They're fibrous tissue. They can vary in length, but is longer than a suture, right? And so this is kind of showing you that area that's right there. Now, the sheet that you can see sometimes besides this is basically the types of membranes that are found here between both this tibia and fibula and the other ones that come together, and then essentially you can kind of see sometimes sheets being formed here, right? So you can find this also in the radius and the ulna, right? And basically this membrane that you find, or the sheets of membrane, are interosseous membranes. And you can find those basically in both those kind of towards the distal part of those bones. Now, sutures are essentially these guys right here, right? You can see them all the way through. And these joints are held together with very short interconnecting fibers. And basically these bone edges here end up becoming interlocking. And the only place that you find these essentially are in the skull. Now, where do these sutures come from? What was the only part in that alien baby skull that I made you guys identify? So it's the fontanelles, right? I don't know why I ended up putting that there. The fontanelles are basically the membrane covering openings in the skull, right? And you find those in the babies or infants, right? And so this goes from being those fontanelles into this through the process of intramembranous ossification. Right? Endochondral ossification happens for all the other basically like long bones and continues on through your childhood into your adolescence with growing, right? But this happens through intramembranous ossification. And so what kind of movement do we find here in this type of suture? Hopefully you put synarthrotic, right? There's no movement here. How about for the last one? Let's go back one. How about what kind of movement that you find here? This one is, oops, amphiarthrotic. This guy has slight, ever so slight movement. Okay. So gamphrosis is basically the ligament that you find within your teeth. These are Pagan socket fibrous joints. So the technical word is the periodontal ligament holds teeth in their actual socket, right? And so on here, gamphrosis is this joint formed by the union of the cone-shaped bone here, right? To the bony socket. So you can see this ligament that is right in there, essentially. And so an example of this, gamphrosis, is the tooth fastening to the maxilla or the mandible of a periodontal ligament. And what kind of movement do you think is here in this area? Hopefully you put synarthrosis, right? It is immovable, or you're hoping it is. You don't want your teeth to move, right? So those are the main types of fibrous joints. So let's go for a question here really quick. The types of fibrous joints are what? You have syndesmosis or ligamentous are held together by interosseous membranes. B, symphysis united by hyaline cartilage. C, sutures are held together by interosseous membranes. D, gamphosis are Pagan socket fibrous joints like the periodontal ligament. Or E, synchondrosis are held together by interosseous membranes. Which one of these are correct? So I'm going to give you a few minutes, or more like a few seconds, to read through them, figure out which ones are examples of fibrous joints, and then we'll go over those answers. So, A is correct. The name of the type of fibrous joint is there, and it's held together by those types of membranes, right? Symphysis is something we have not even talked about. We will hit on that here in a few, right? Sutures are held together not by these types of membranes, but what's known as a sutural ligament. So that would be wrong. And that sutural ligament is still dense connective tissue, just like it was in the previous examples. Gamphosis is the periodontal ligament here, right? And synchondrosis is one, again, we have not even talked about. So on this, the types of fibrous joints, this is an example of one, but this is an example of one, but the description is wrong. The rest of them are correct, though, that I circled. So let's talk about cartilaginous joints here. So in here we have two kinds. We have synchondrosis and symphysis that we're going to be talking about here. So basically cartilaginous joints are held together by hyaline cartilage or fibrocartilage that connects the bones of the cartilaginous joints. And so we're going to talk about the two types. Here we're going to discuss synchondrosis, and that's formed by a band of hyaline cartilage. Now, within these can be temporary structures that disappear during growth. So an example of these are the epiphyseal plate, or what we know as the growth plate, right? And we talked about that in lab. And basically here, when we look at this, when we talk about the epiphyseal plate essentially ossifying over time, and disappearing, that is from endochondral ossification. And so that's essentially whenever that forms, secondary ossification and long bones form from this endochondral ossification that essentially forms the epiphyseal plate. And that epiphyseal plate plus the bone cartilage is called that synostosis, right? And these are basically immovable joints. So immovable joints essentially are considered what? Think sadism. That's synarthrosis. And you can remember this synchondrosis with synarthrosis. It starts the same. And so this is giving you an example of two of those type of synchondrosis joints. You can see the epiphyseal plate, that's temporary hyaline cartilage joint until 18 for female, 21 for male. Those are average ages, of course. And then you can see there the joint that's located between the manubrium of the sternum and the basically the joint between the first rib and the sternum there, right? Symphysis essentially is an example of this type of joint, and you can see it in the pubic symphysis and in the intervertebral discs here, right? And essentially you can see this one here is made up of fibrocartilage together, right? And so these have essentially they're considered, for the most part, having slight movement. So they are amphiarthrotic. For most time, this one is considered immovable, but sometimes it can be slightly movable during childbirth. And then, of course, these guys here, whenever you bend your back or go forward, they have some slight movement, but it's kind of like this forward and backward or slight. They're not moving to the extent of, say, a synovial joint that we'll talk about here in a moment. Now let's talk about the types of cartilaginous joints and which one are correct here. So we have syndesmosis or ligamentous are held together by the interosseous membrane. B, symphysis united by hyaline cartilage. C, sutures are held together by this interosseous membrane. D, kyphosis are pegs and socket fibrous joints like the periodontal ligament. Or C, synchondrosis are held together by the interosseous membrane. Which is correct there? I will give you a few moments to review. Well, hopefully, if you said only B, you would be right. The other ones here that are essentially are considered the types of ones we're looking at, or you have here, right? And these other guys are not examples of cartilaginous joints, right? So hopefully that helps a little bit. So now let's talk about the big baby, which are essentially synovial joints. So synovial joints are bones separated by fluid-filled joint cavities. They are all diarthrotic, which means what? Sadism, right? They are movable. So this includes all limb joints, most joints of the body, and there are 6 characteristic features that we're going to talk about here. So here's a perfect example of a synovial joint, and what you'll notice, let's look at all the different parts here. So these guys have what you'll notice here known as joint cavities, right? And so these are called joint cavities or synovial cavities. And they contain, basically they are small fluid-filled potential spaces. Right? So when you're looking at a synovial cavity, that's one of the first things you'll probably see whenever you go to do it. Now, if you look at the end of the bones on here, all of them have this articular cartilage, and it's basically made of hyaline cartilage, if you see there. And this helps to prevent crushing of the bone ends. Now, if you look here, so this is the hyaline cartilage here, right? And then if you look here, you have the articular capsule. And so this is also known as a joint capsule. And it has 2 layers, right? You can see here, this one. So the first thing you have, which I'm going to write over here, is basically this external area. That is the fibrous layer. And this guy is made up of dense, irregular connective tissue. And then you have basically this inner part here, which, let me get up here really quick. Go. You'll see is this part that is right there, right? So that's the part when they mean inner, it's towards the actual inside or that cavity, that joint or synovial cavity. And so the synovial membrane is this inner part, and it's made of loose connective tissue. And this guy, if you notice, makes synovial fluid. Okay. And so let me talk a little bit about synovial fluid. So synovial fluid is viscous. So if you're wondering, viscous, it's something that's like the liquid is thicker. So if you look at syrup versus water, syrup is more viscous than water. This stuff is slippery, and it's a filtrate. And it's a filtrate of plasma and hyaluronic acid. Its main function is to lubricate and nourish articular cartilage. And it's also there to help to remove microbes and debris because it contains phagocytic cells. And phagocytic cells are those things that come up and basically eat or remove things that can be detrimental to the area. So it's to remove microbes, which are bacteria, and debris. So those, if you look through, are basically the main parts of a synovial joint. Now, on top of all of this, you'll also notice throughout, like if I go up here, you'll notice all of these ligaments throughout. I'm going to go back to that picture here. So you also have, on top of all of that, ligaments as well, which they point out here, but there's several throughout, depending on the type of joint you have, right? So ligaments are there to help reinforce. So they help reinforce the structure. So you can have them on the outside and you can have them on the inside. And then the last part of all of this that you can get are nerves and blood vessels. So what do you think nerves do? Yeah, the fibers there detect pain. They help to monitor position. And stretch. And the capillary beds, which you'll learn in part 2 about the different types of blood vessels that are present in the body, one of them being capillaries. But the capillary beds are what supply the filtrate for the synovial fluid. So that gets our final part, and so there are essentially 6 different components, right, of the average synovial joint. And a review over those again, there's articular cartilage, the joint and synovial cavity, the articular joint capsule, the synovial fluid, the different types of ligaments and nerves and blood vessels. So perfect examples of synovial joints, you can think your shoulder joint, elbow joint, hip, and knee joint. And we looked at those in class, and we're going to get even more specific on the types of synovial joints, because these joints have can be subdivided into different types of synovial joints. These are just examples or general examples. So, true or false? Synovial joints are diathoracic joints that are separated by fluid-filled joint capsules and include all limb joints. True. Good job. So let's take an example and look specifically at one type of joint here, and that is a knee joint, right? And you are responsible for knowing the ligaments of the knee joint, and this should be pretty forward because we've already talked and looked at this in class. So let's go through this really quickly. And so let's start with the anterior cruciate ligament. And make these purple. So the ACL ligament is right here, right? And so you can see anterior is towards the front, right? Cruciate is the type, it's in the middle ligament. So this one that's in the front is the anterior. This is also known as the ACL. And the one that goes towards the back, if you look, you're looking at posterior here, right? And so this is also known as the PCL, towards the back here, right? Let me actually, so this is one, this is two here, right? The next we're going to look at is the medial meniscus versus the lateral meniscus. And so those we're looking at meniscus. You can think of when you pour water into something and it goes kind of scoops down, everybody's looking at the meniscus, so something that goes across, right? And medial, there's both medial and lateral, and that has to do with location. So essentially, when you look at the fibula attaching, this is going to be the lateral side, and the side opposite of that is medial. So if you look at this right here, this is the medial meniscus, and if you look on the other side, this is the lateral meniscus. And these essentially are made up or known as fibrocartilage. So the collateral is going to be on the outsides, right? So you can look at this or this. Again, you know where the medial side is. So essentially what you're looking at here is this guy that's right here. So this is 5. And so it's the tibial collateral ligament on here, and it's also known as the medial. And I'll take both of them, but in terms of, you might want to know them both in terms of the book to see which one they ask on a test. And this one right here is the fibular. It's by the fibia, right? And this one is by the tibia. And this is also known as the lateral collateral ligament. And you can see here, the patellar ligament is towards the bottom of the patella, and then the quadriceps tendon is at the top. So this would basically be going up and just covering this whole knee joint. Now, there is a newer ligament that was discovered a few years ago, and this shows you all the pictures, called the ALL, or the anterolateral ligament, ALL. It was discovered in 2013. And basically, It was a completely unknown ligament in the knee. This ligament appears to play an important role in patients with ACL tears. So you can kind of see it right here, right? So it kind of gives you an idea. So that's what's the amazing thing about science is you think you know everything, and then a few years later, whoop, there it is, and you wouldn't have never known that you had any issue at all or something new, and then they were able to find it. So, there can be a lot of problems that happen more than anything with lateral blows that happen. So you can see on here an example of the knee joint is a very intricate joint that has a lot of ligaments there to help stabilize everything. But if the knee is knocked out and a lot of force is put at the wrong angle, it can cause a lot of problems. So this is showing you an example of a common knee injury where someone, especially in sports, this is showing a hockey puck, but you know, in football, you know, when they go to actually tackle, if you fall just the wrong way, this is what can happen. And so essentially it's showing here the force coming from this lateral side, and basically that is going to blow out several different ligaments here. You can see that you have this ACL being torn here, the medial meniscus, and this tibial lateral collateral. And so this can cause a bunch of problems in stabilizing. The great thing is there is surgery that they can do for this now. That's very, very advanced. This is also showing you probably the most common fracture that can happen within your knee. And this is what we talked about in class, a tibial plateau break. And you can see a lot of times this happens because you can see that you have this fibula that's right underneath it getting pressure up here. So this part of the tibia is more likely to break. And you can see this picture of it here and one here where you can see that it's just kind of coming off on that side. And this is one of the most common breaks that you can get in the knee joint at the bone. So here are some, just to kind of show you some. There's a few examples in here that are not knee related or joint related issues, but a majority of them are. If you don't like watching people getting hurt, you probably don't want to watch this.
Everything. Will Allen coming like a truck. Bust up the screen.
So if you look over here, you can see how he's moving and the leg is not.
Bust up the screen. They bust up everything. Will Allen coming like a truck. Will Allen with two big shots, one on Winslow and then
so you can see. Oops, what did I do? No. Sorry, guys. So you can see he's running. And you can see right here that he's coming in there. He's doing that kind of sideways hit right here, and the leg is basically going like that because he's breaking all of those knee ligaments. Oops.
Oh my goodness. Oh Lord.
There's a couple of them. Again, you can see how this is remaining. It's not moving, but it's going completely. You can see here that the leg should be going and his foot should probably be going this way. And it's going down like that.
And no doubt that Brown caused the fumble there, and that ball will stick.
And you can continue to see. There you go. Oops. Here, if you look, you can see basically it's put that pressure, and now his foot is basically going completely sideways here. And that's not good.
There, and that ball will.
And at this point, he is completely forward, right? And his leg is completely back and going straight down. So there are several tears that have happened there. So there's a couple of them, just to give you an idea.
Immersion media, next generation training and instructional media. Years ago, a torn ACL was a career-ending injury for an elite athlete. With advances in technology, surgical procedures, and rehabilitation, however, an elite athlete now has an excellent chance of returning to high-quality sports participation. To keep the joint stable, a set of 4 ligaments keeps the knee in a hinge-like position while you move. 2 ligaments on either side of your knee joint, the medial and lateral collateral ligaments, connect to either side of your femur and tibia and limit shifting movement left or right. The other 2 ligaments, the anterior and posterior cruciate ligaments, connect from the base of your femur to the top of your tibia. They cross each other and prevent the knee from excessive forward and backward movement, as well as twisting movement in either direction. If a movement is forceful enough, any of these ligaments may snap, including the ACL. Once torn, the ACL cannot regenerate or repair itself. The ACL reconstruction operation is now typically a 1-hour outpatient procedure, performed successfully more than one way. We'll examine one of the more common methods used in ACL reconstruction. The entire surgery is completed through just a few tiny incisions. One is made for the insertion of a tiny camera and to deliver fluid to establish a clear view of your joint. 1 or 2 additional incisions are made on either side of your kneecap to give the surgeon access to your joint. 1 very small incision is made to anchor the new grafted ACL in place. To start the procedure, the surgeon will insert a probe to inspect the damaged joint. A small motorized shaver will then be used to remove the damaged ACL and prepare the area for the new one. In every case, a surgeon will also inspect the entire joint to determine whether there is additional damage warranting other repairs. Then, the surgeon will use a device called a retro-flip cutter to create a tunnel through the femur and into the knee joint. The surgeon will also create a tunnel through the tibia and into the knee joint from below. These 2 tunnels become the source of the anchor points for the ACL graft. In most cases, the surgeon will harvest a portion of your own hamstring tendon to use as the graft. Using your own tissue reduces the likelihood of your ACL rupturing again, and is a reason some surgeons decide not to use a tendon harvested from a cadaver. A surgeon will harvest more hamstring than needed to avoid the challenge of not harvesting enough. To the patient's benefit, hamstring tendons consistently regenerate over time as well. Your surgeon will prepare the harvested hamstring and pull it through the upper hole and into the lower hole just taut enough to mimic your original ACL. A small grappling hook will anchor the upper end of the graft, and a screw will stabilize the lower end. The screw is usually bioabsorbable, meaning your body will incorporate it into the bone over time. The graft from your hamstring tendon will act as a scaffold upon which a new ACL will grow. Over time, the hamstring graft undergoes changes and is strengthened, leaving a strong, viable ACL.
Okay, so hopefully you found that kind of interesting and makes sense why now sports, why at one time it used to be a completely kind of debilitating, crippling injury where you couldn't play sports anymore, and now they essentially can come back to and be able to be successful in the field. So let's do these. Here's a few questions to see if you can label. And remember, you'll need to be able to do this in the lab as well. So if you look at this picture, which ligament is that? Hopefully you said the ACL. And just a reminder, you have to use anterior cruciate ligament. I will not accept ACL on any of your exams. How about this one? This is the fibular collateral ligament, also known as the lateral collateral ligament. And this guy right here, what is this one? Posterior cruciate ligament, otherwise known as the PCL. Again, with that, all of these, you will need to be able to know the full name and not just the abbreviations for them. And the fibular condyle fracture is the most common type of bone fracture associated for knee injuries. And what is that? That would be false. You guys know it's the tibial plateau fracture, right? And so now let's get into the fun part and talk about the 6 different types of planes, or not planes, synovial joints, right? We have plane, we have hinge, we have the pivot, we have the condylar, which is also known as the, what we did in class, the ellipsoid, right? The saddle and the ball and socket. So the plane joints here are basically articulating surface near flat surfaces. So this is the type of plane, and the movement that you'll expect here is sliding or twisting, right? And this means that it is non-axial. And you can find these basically in the carpals, as you can see here, or the tarsals. The next is the hinge joint. And so on this joint, you'll notice that we have a convex surface that meets with a concave surface of another. So you can see right here, right? Those two. It's what they're calling here this trough and the cylinder. They are concave and convex. And the movement you're expecting to see here is basically what we'll learn in a second is flexion and extension. So in here we have uniaxial movement. And you can see this if you look here right between the humerus and the ulna, and you can also see it in the phalange joints. So here we have our pivot joint. And here you're going to have a cylindrical surface of one bone that articulates with a ring of bone or ligament. So here, the movement that you're going to get is rotation. So if you look here, here's a perfect example right there, right? The proximal end of the radius and the ulna. Here it's called the radial ulnar joint. So this is the radius, right? Pardon me. This is the ulna. And you can see the joint is right there and incorporated that round sleeve of ligament. And so this is, again, uniaxial. Oops. No. Sorry, guys. Let me get back in there. And so the next one we're going to look at is the condylar, or what's known as the ellipsoid. And so on here, you basically are getting an oval shape condyle that is going to articulate with an ellipsoid or elliptical cavity, right? So you have, and it shows it right here, right? You get this kind of part that comes in like a big bowl on one side, and then something can fit into that bowl. And so on here, the movement that you see is biaxial. You can see it can move this way, medial, lateral, or anterior and posterior, right? And the perfect example of where you find here are basically in the metacarpal phalangeal joints here. So they show you those that are basically right in there between the metacarpals and the phalanges here. And you can also find these in the wrist joints as well. Saddle joints. So basically in a saddle joint, you're going to get the articular surface of both a concave and convex region that are basically one fitting complementary to the other. So if you look, you can see here it looks like a saddle, right? That's why it's called a saddle joint, because essentially this looks like the saddle on a horse, and these are the two legs, right, for whoever it is that's going to be sitting on the horse. So essentially with this, the movement is various in two planes. So essentially it's considered biaxial. And the examples that you see here are in these basically carpal to metacarpal bones in the thumb. And the last one is the one that we've looked at a few times, is the ball and socket, right? And so basically you have this ball here, right? A ball-shaped head that articulates in this cone or cup-like socket. And so this basically, if you look, moves this way, moves this way, moves this way. So it has all plane rotation, which means it's multi-axial. And so perfect example here, they're showing you the shoulder socket, but you also have it in the hip. And so how all this works is these are important because they help bone move. And so skeletal muscles will contract, and that's what produces the movement at a synovial joint. Now, how this moves is that when you have it, one end of the muscle is always attached to what's known as a stationary bone in a joint. So that stationary, where that muscle is attached, that doesn't move, that's known as an origin. And then there's also a second muscle that's attached to a movable part of the bone in a joint. And so that is what's known as an insertion. So if you were going to do something like try to flex your muscle or flex your arm, you know, the part that's by your hand, the distal part of your arm, moves up towards your head. And so essentially, the part that's towards the top where your bicep actually is, that up there that's not moving at all is called an insertion. And then down towards the bottom or distal end, there's going to be an attachment down there that essentially when the muscle contracts, it gets shortened basically because they slide over each other, the muscle fibers do. And that is what's known as an insertion because it's going to move. So when muscles contract, the joint ends up moving, and that's what allows us to move. So if you see he moved his arm closer, so let me move back here really quick. So when we go through this, you can see on here, right, he's going to move his arm closer. So where this, let me pause this really quick. If you look here, his arm started down here and it moved up. So this angle reduced. So that's known as flexion. Now, if he takes his hand and moves it down here, right, this is reduced, this is flexion. If he takes this and then this angle here gets bigger, that's known as extension. So dorsiflexion, as you can see here, dorsiflexion, his foot started here and went here. And you can see this angle is getting shorter. So this is the dorsa, where here, plantar flexion, you're going to notice that here it's going to go this way. And so you're increasing the angle, and that is what's known as plantar flexion. So dorsiflexion is up. Plantar flexion is going to be like if you're a ballerina getting on your tiptoes. So elevation, you can see that your shoulders started down here and then they moved up. So that's elevation. Now when your shoulders stay here and move down, that's known as depression. So now we have what's known as eversion. So when you're taking your leg and your foot is moving out, right? That's what I know as eversion. And I like to think it's exiting as going out, right? Now, if you bring your foot in or towards the plantar surface, so eversion, the bottom of your foot or your foot moves out, right? And you'll notice this. If you're turning your foot in where you can see the inside or the bottom, that's inversion. So we're thinking about the plantar surface here, which is on the bottom. Think plantar, and that's the, when we were looking earlier and we were looking at the plantar flexion, you can think you're planting your tiptoes down on the floor. That's a plantar surface. So when you move it out, the bottom out, you can see eversion. When you're moving it in, it's inversion. So you see eversion there, it's going out. And then inversion, the bottom will come towards the inside. So abduction and adduction. I like to start with adduction because if you notice, if we started here, his arm was here, and then he added it to the body or the center, that's known as adduction. Now, if you start with it by your body and you move it up or away, that is what's known as abduction. So moving away from the midline is ab with the B duction. Moving it toward the midline and adding it to your body is adduction. So here you can see if it's rotating it out, it's a lateral rotation. If you're rotating it in, it's a medial rotation. So I like to think pronation and supination. I like to say with the idea of, oops, where'd he go? He's gone. No, give me a second to pull this back up. Here. So pronation is the idea that you start with your hand up and then you flip it down so where you can see those. So that's pronation. Now, I like to think with supination is when you go and you see somebody, you go, "What's up?" Or, in short, right, sup. And when you do that, normally you might give somebody and try to flip your hand over to give a high five. So that's how I remember what is considered palm up is sup, like what's up in the hand, high five, or, you know, doing the high five in your hand. So, and then if you know, just pronation means the opposite of that, and basically to put it down so that if somebody tried to give you a high five there, they'd hit the top of your hand and that would be awkward and weird, right? So that's pronation, where supination, or what's up, is when this is flipped over. So that person you could give a high five to. So if you see here, retraction, right, you'll notice here that his shoulders are going back. Protraction, they're going to be pulled forward. As you can see here, this angle decreased. So all those are pretty straightforward. The only one with this retraction, protraction, you can also, on here, retraction. A perfect example for retraction is also, besides moving your shoulders back, it also means just moving things back. So if you have your head and all of a sudden you push your head back so you can see up to the ceiling, that is considered retraction. And then if you move your head forward like you're trying to get your chin to touch your chest, that's considered protraction. So it just shoulders forward or head forward, right? Head back or shoulders back are the two examples. And so those are all the different ones that we've talked about, and you should be able to identify every single one of those movements. And we'll go over them. The only thing we didn't talk about is circumduction, and that's when you're making circles with something. So if you stick your hand out and you start kind of making circles in the air with that, like think circumference as in circles, that's what circumduction is. It's just making circles. And how that is different than rotation is basically on rotation, you're taking whatever limb you're looking at and you're keeping that limb steady and not moving it, and you're rotating about that axis that your limb creates. Or circumduction is actually creating a whole circle with whatever limb you're looking at. I'm not going to do that one. So here's a little video that can kind of help you a little bit on different movements.
Man, I'm showing y'all the movements. Listen to me. Man, I'm showing y'all the movements. That's what you'll see. Anatomical movements. Anatomical movements. Yeah. Back up in the mix like that. To show you what I mean so you won't fall flat. These terms that you need to get you up to speed. The words are at the bottom, you can listen and read. First things first, you should lift your wrist. Then decrease the angle, something like this. When you do that, you could call it flexion. Increase the angle, and that's called extension. Now, put your hands by your side. Rotate your thumbs so they face outside. When the thumb points out, lateral's how it's facing. And when it points in, it's medial rotation. Movements. Listen to me. Man, I'm showing y'all the movements. That's what you'll see. Anatomical movements. Anatomical movements. Put your arms out and move them round, round, round. Circumduction's moving round, round, round. There's a few terms left for a discussion. Arms by your side, moving away is abduction. Now keep your arms out, and when you move them back in, that movement there is adduction. These next two movements you're really gonna love. You can do them in the club, looking like a shoulder shrug. Remember this song next time you're with the patient. Lifting up your shoulders is called elevation. Opposite of that is what's next in our lesson. Lowering your shoulders, that's called depression. Last one is supination with the palms up. Pronation, sudden spacing down, that's what's up. Movements, movements, movements. Anatomical movements, movements, movements. Next up is something funky, sorta neat, cause we gotta talk about some movements of the feet, yeah. That's how your feet be working, roll your foot so it angles out in that Z version, yeah. And when you roll it back in, that movement there is inversion. The next term you'll learn is something you use often. It's the movement you'll do if you're ever moonwalking. If you're picking up just what I'm putting down, lift your foot up and point your toes towards the ground. If you're unsure of the term and left guessing, bottom of the foot is plantar, the move is plantar flexion. Put your foot down and leave it like it's resting. Lift your toes off the ground, it's dorsiflexion. And that's it, all the terms you need. Just remember this song and you're sure to succeed.
So I'm going to upload a little class activity that you can use on your own, and I'll go through it in a separate video. It's going to be a little bit later today, but if you want to practice any, you can practice those terms. Now, the structures associated with those are the bursae, and the bursae in the synovial joint is a sac that's lined with synovial membrane. It contains synovial fluid, and it's there to help reduce friction where ligaments, muscles, skin, and tendons and bone rub together. The tendon sheath is there as well, and it's helped to basically mediate out basically it's elongated bursae, and it's wrapped completely around the tendon subjected to friction to help kind of alleviate any of that. And you can see those both here in this picture, that you have this bursae that's right here, and basically this tendon sheath that's right here as well, that helps to alleviate some of that friction. Now, on here we have some terms that are essentially used, that diseases that affect the joint. So we have the sprains, and this is basically overstretching or tearing of the cartilage. And this is associated with the joints, right? And it's a common injury that you see in the wrist and the ankle. The next is what's known as a dislocation, otherwise known as election. And this is a joint injury that forces bones out of joints. And out of their position. So this is common in the shoulder. Partial dislocation, or what's known as a subluxation, is when they partially come out of location. And this is common for the radius or the vertebrae. Bursitis is inflammation of the bursae. And this is caused by overuse. So you can think of this in the ankle or elbow, and it's what's known as tennis elbow. Hemarthrosis is bleeding into the joints. It's normally caused by injury or a bleeding disorder or tumor/neurological condition. Arthrogala is basically joint pain. And it's associated with injury or arthritis. RA, or rheumatoid arthritis, is an autoimmune disease. And basically attacks the synovial joints. Specifically, it attacks the synovial membrane. It causes them to swell, turn red, and it's very painful. Now, the problem with this is fibrosis may occur because of this, and that basically can fuse bones together. Which is known as ankylosis. And it's a systematic disorder, which means it can cause damage to other tissues and organs as well. Osteoarthritis is a degenerative disorder. So it affects older people. Its cause is unknown. It basically starts when you start wearing down the articular cartilage, and then you get this bone-on-bone contact. And it usually affects one joint, and that can cause pain, stiffness, and swelling. Gout. It's a form of arthritis it is caused by the accumulation of uric acid. And it causes acute attacks of pain and redness and the feeling of joints being on fire. And the last is Lyme arthritis, that's caused from Lyme disease. So it's a bacterial infection that's passed from tick bite. And so it can cause a temporary arthritis system of aches and pains. It's common in dogs and people who are bit by ticks. So those are all the disorders, and that will finish us up for joints. If you have any questions, just let me know, guys. Other than that, have a great afternoon.